Imagine the scenario, right? You have a patient who has been admitted for, well, severe, completely debilitating depression.
Right.
They are profoundly hopeless, just entirely lethargic, and they've explicitly expressed a desire to die.
Yeah, a really high-risk situation.
Exactly. So you start them on a new antidepressant regimen, and a couple of weeks go by.
Okay.
You walk onto the unit, and suddenly they are out of bed, they're showering, they're making their bed, they even smile and say good morning to you.
Which seems great.
Right. As a medical professional, your first instinct is to, celebrate. You think, wow, the medication is working, we saved a life.
Yeah, that's the natural human response.
But in the counterintuitive and honestly often terrifying world of psychiatric nursing, that exact moment of apparent recovery is when that patient becomes the absolute highest possible flight and safety risk on your ward.
It is it's one of the most dangerous paradoxes in medicine, honestly.
Yeah.
Giving a patient a life-saving medication and having the very first sign of its efficacy be a dramatically heightened risk of a suicide attempt.
And understanding exactly why that happens is the kind of clinical synthesis that, separates a novice from an expert. So welcome to the deep dive.
We have a highly specific mission today.
We really do. You, the listener, are staring down the barrel of a massive, cumulative mental health nursing final exam. We are talking 78 hard-level NCLEX-style questions.
Yeah, and we have spent days poring over the stack of materials you provided us. I mean, the comprehensive Angwin Final Study Guide, the hundreds of practice questions.
Oh, the practice questions are brutal.
They are. And those specific exam traps your professor loves to deploy, plus those incredibly dense lecture notes covering everything from, complex psychopharmacology to theoretical nursing models.
It is a vast amount of material. I mean, we're covering torts, involuntary holds, profound psychiatric disorders, all of it.
But our goal here isn't just to read you a list of facts to memorize.
Right. If you just wanted flashcards, you wouldn't be here listening to us.
Exactly. Our job is to build the architecture of understanding in your mind. We need to look at the mechanisms, the pathophysiology, and the real-world clinical realities behind these concepts.
Because once you understand how the machine works, or I guess in this case, how the brain and the therapeutic environment work, you don't have to memorize anything. You'll just know it.
Precisely. So let's start building that foundation. Before we can even consider medicating a brain in crisis or diagnosing a complex thought disorder, we have to establish the primary instrument of psychiatric care.
Okay, lay it on me.
In a medical surgical unit, your instruments are, IV pumps, scalpels, cardiac monitors. But in mental health, the primary instrument is you, the therapeutic relationship.
Which brings us right to Hildegard Peplau and her theory of interpersonal relations.
Yes.
Now, the study guide flags this as a really high probability exam topic. But looking at these four phases, orientation, identification, exploitation, and resolution, I mean, it feels very abstract.
It does, I agree, until you put it into a clinical context. Peplau was revolutionary because she defined nursing not as something done to a patient,
Right.
but as a significant therapeutic process happening with a patient. So let's break down the phases, starting with orientation.
Okay, orientation, that's the initial encounter. Right.
Yes. The patient is usually operating from a place of intense anxiety or crisis at this point.
Yeah.
The nurse's job here is establishing trust, defining the parameters of the relationship, and clarifying the roles.
Right. But what does that transition into identification actually look like? Because the notes say identification is when the patient begins to actively participate in the relationship and care planning.
Right.
To me, that just sounds like the patient finally agrees to read the brochure you handed them.
Well, it's much deeper than that. Identification is a fundamental psychological shift.
Oh, really?
Yeah. The patient stops viewing themselves as a passive victim of their illness or their circumstances, and they begin to identify with the nurse and the treatment goals.
Okay, I see.
They start to feel capable of dealing with the problem. They might say, okay, I understand why my anxiety is spiking. What can we do about it?
That makes a lot of sense. But then we hit the third phase, and I really have to push back on the terminology here. Exploitation.
No, it sounds awful.
Right. I mean, in any other context, exploiting a patient is a career-ending ethical violation. Why use that specific word?
It is a jarring term for modern ears.
Yeah.
Absolutely. But in Peplau's clinical framework, the patient is not the one being exploited. The resources are.
Oh, the resources.
Okay.
Yeah.
The patient is fully utilizing or exploiting the therapeutic services available to them. They are doing the hard work.
Got it.
They are practicing the coping mechanisms you discussed. attending the group therapies, and actively mining the relationship for everything it can offer to facilitate their healing.
Okay, so let's unpack this. It's like a gym membership. Orientation is getting the tour of the facility.
Yes, exactly.
Identification is meeting with the personal trainer and agreeing on a workout plan. And then exploitation is actually sweating on the treadmill and using the heavy weights.
That is an excellent analogy.
Yeah.
Which brings us to the final phase, resolution. The goals have been met, and the therapeutic relationship must be terminated.
And this is exactly where the exam traps are waiting.
Oh, absolutely.
Because human nature dictates that if you've gone through a profound, vulnerable journey with someone, you naturally become friends. But the study guide is incredibly strict about this. Resolution is not trading phone numbers.
It cannot be. The therapeutic relationship is entirely asymmetrical by design.
Right.
It exists solely to serve the needs of the patient. If a nurse transitions that into a social relationship, they are fundamentally violating that clinical boundary.
So it's a hard stop.
Yes. On the exam, if you see an option where the nurse agrees to meet a discharged patient for coffee to just check in, that is the wrong answer.
Do not click that box.
Exactly. The relationship ends. That boundary protects both the patient's independence and the nurse's professional integrity.
Okay, speaking of boundaries, let's transition from the external boundaries of the nurse-patient relationship to the internal boundaries patients use to protect their own minds.
Ah, the defense mechanisms.
Yes.
The mind's armor.
Freud's concept of ego defenses. These are unconscious cognitive distortions. And we really must emphasize the word unconscious.
So they're doing it on purpose.
No, the patient is not intentionally lying to you. Their brain is automatically deploying these mechanisms to manage severe stress, maintain a sense of control, and protect the ego from devastating anxiety.
Let's decode the heavy hitters for the exam then. First up, projection. This is when a person takes their own unacceptable feelings and projects them onto someone else.
Yes. A classic clinical presentation here would be a patient who is deeply harboring aggressive, hostile feelings toward the nursing staff.
But they will genuinely believe and lightly complain that the nursing staff is out to get them. They project their internal hostility outward to avoid confronting them.
Wow. Then there is rationalization. I call this the excuse-making machine.
But it's highly sophisticated excuse-making. Rationalization creates a logical-sounding, socially acceptable explanation for behavior that is actually driven by unconscious impulses or failure.
So what does that sound like on the floor?
Well, a patient doesn't say, I relapsed because I have a profound physical dependency and I didn't use my coping skills. They say, I relapsed because my boss fired me and anyone would drink after that.
Right, it protects the self-esteem. Next, we have regression, which is reverting to an earlier developmental stage under stress.
Yeah, it's like a hospitalized adult throwing a literal temper tantrum.
And then denial, which is a massive clinical hurdle, particularly in addiction, right? It's the outright refusal to admit that a painful reality even exists.
And we should contrast those maladaptive mechanisms with a highly adaptive one, which is sublimation.
Sublimation, okay.
Yeah. Sublimation involves taking a primal, unacceptable impulse and channeling it into a socially productive outlet.
The classic textbook example being someone with intense, aggressive, violent urges deciding to become a professional boxer.
Exactly.
They get to punch people, but society applauds them for it instead of arresting them.
Right. It is a mature, healthy defense mechanism. But to understand the true chaos of a psychiatric ward, we really have to look at a highly destructive defense mechanism known as splitting.
Splitting, yeah, this is deeply tied to borderline personality disorder. Let's paint a picture of how this actually looks on the floor, because the notes highlight this as a critical concept.
Okay, so splitting is a rigid black and white style of thinking. The pathophysiology of borderline personality disorder, or BPD, involves severe dysfunction in emotional regulation.
Which is often linked to the amygdala, right?
Yes, hyperreactivity in the amygdala. These patients experience emotions at a profoundly intense, agonizing level. Because their internal world is so chaotic, they attempt to control their external world by simplifying it into absolute extremes.
So there is no middle ground.
None. People are either perfect angels or malevolent demons. There is no gray area.
So in a clinical scenario, the patient tells the day shift nurse, you are the only one who listens to me. You are a brilliant nurse.
Exactly.
And then they say the night shift nurse is abusive, ignores me, and just wants me to suffer.
And if that day shift nurse is inexperienced, their ego gets stroked. They might think, wow, I am a great nurse, and the night shift really does need to step up.
Right, they buy into it.
Yeah. Meanwhile, that same patient will tell the night shift nurse the exact opposite story 12 hours later.
Oh, wow.
If the nurse and staff isn't communicating, Splitting will literally tear the unit apart, causing staff members to turn on each other. The intervention here is strict, unified limit setting across the entire clinical team.
That emotional whiplash leads us right into the broader categorization of personality disorders. The exam requires you to know the clusters.
There are three main clusters. Cluster A encompasses the odd or eccentric disorders. This is where we see paranoid and schizoid personality disorders.
Okay, so cluster A is odd and eccentric.
Yes. Cluster B is the traumatic, emotional, or erratic group. As we just discussed, borderline personality disorder lives here, alongside narcissistic, histrionic, and antisocial personality disorders.
Got it. And the last one.
Finally, Cluster C includes the anxious or fearful disorders, like avoidant and obsessive-compulsive personality disorder. And a quick note, that is not to be confused with OCD, which is an anxiety disorder.
That's a good distinction. I want to stop and look at antisocial personality disorder for a second because the professor's notes specifically mark this as an exam trap.
Yes, they do.
The defining feature you absolutely must know is a profound lack of remorse.
It is a chilling clinical presentation, to be honest. When we look at the brain of someone with severe antisocial personality disorder, we often see underarousal in the prefrontal cortex and a muted response in the amygdala.
Meaning what, exactly?
Meaning they literally do not experience anticipatory fear or empathy the way a neurotypical person does.
Wait, so they aren't necessarily confused about right and wrong? Like, they know the speed limit is 65. They just do not care.
Exactly. They understand the rules of society perfectly. In fact, they are often highly intelligent and very charming.
Yeah.
They simply view those rules as obstacles to getting what they want, and they feel zero guilt about manipulating, exploiting, or harming others to achieve their goals.
Which raises a terrifying question, I think. If a patient has no empathy and they are escalating into aggressive behavior, how do you manage them?
It changes the whole approach.
Right, because when therapeutic communication fails and a patient becomes a danger to themselves or others, we pivot into an entirely different realm of nursing.
We enter the legal and ethical battleground of psychiatric care.
Let's talk about involuntary legal holds. A fundamental principle here is that psychiatric patients retain all their civil rights, like they can vote, they can sign contracts, but there is one highly specific exception.
The right to leave the facility.
Right.
In California, the initial mechanism for this is the 5150. That's a 72-hour hold, which can be extended to a 5250, which is a 14-day involuntary hold.
And what are the criteria for that? You can't just put someone on a hold for no reason.
To meet the criteria, the patient must be a danger to themselves, a danger to others, or gravely disabled.
Gravely disabled meaning?
Meaning they cannot provide for their basic needs of food, clothing, or shelter due to a mental disorder.
But the state can't just lock someone away indefinitely without due process. The study guide mentions the writ of habeas corpus.
Yes, a writ of habeas corpus is a fundamental legal right. It is a formal mechanism where the patient demands to be brought before a judge to challenge the legality of their confinement.
Okay.
The hospital must then prove to the court that the patient still meets the criteria for the involuntary hold.
And what if the patient is on a hold but refuses to take the antipsychotic medication that would actually, make them better?
That brings us to Reese hearings.
Okay, Reese hearings.
Being on an involuntary hold means you cannot leave, but it does not automatically mean you lose the right to refuse medication. A Reese hearing is a specific legal proceeding to determine if the patient lacks the mental capacity to make a reasoned decision about psychiatric medication.
So if they lose the hearing?
If the judge determines they lack capacity, the facility is granted the authority to medicate them involuntarily.
So we have the right to challenge confinement and the right to refuse medication. What about the right to privacy? Because I was always taught HIPAA is the absolute unbreakable rule of healthcare.
It is fiercely guarded, but it is not absolute.
Really?
The exam will test your knowledge of where confidentiality ends. The line is drawn at public safety. Nurses are mandated reporters.
Right, I've heard that term.
If you suspect child abuse or elder abuse, you are legally obligated to report it to authorities. You do not need absolute proof either. Reasonable suspicion is the threshold.
And then there is the Tarasoff ruling, the duty to warn and protect. This comes from a tragic historical case, right?
Yes. Tatiana Tarasoff was a university student murdered by a man who had explicitly told his university psychologist about his intention to kill her.
Oh, wow.
The psychologist informed the campus police, but no one warned Tatiana.
It's awful.
The resulting landmark legal ruling, established that if a patient communicates a serious threat of physical violence against a specifically identifiable victim, the healthcare provider has a legal duty to warn that victim and protect them, which includes notifying law enforcement.
So confidentiality has limits.
The protective privilege of confidentiality ends where public peril begins.
That is a guaranteed test question for sure. Now, let's clear up another massive legal trap, and that's the difference between the torts of assault and battery.
Okay, yeah.
In casual conversation, people use them interchangeably all the time, but legally, they are distinct, right?
Very distinct. Think of assault as the psychological component and battery as the physical component.
Okay, break that down.
Assault is the threat of harm. It is any action that produces a reasonable apprehension in the patient that they're about to be touched in a harmful or offensive way without their consent.
So if I hold up a syringe of Haldol and say, if you don't stop yelling, I'm going to inject you right now, that is assault.
Precisely. You haven't touched them, but you have created the fear of unconsented contact.
Got it. And battery.
Battery is the actual execution of that threat. It is the unconsented physical touching. If you grab that patient's arm and plunge the syringe in against their will without a legal emergency order, you have committed battery.
Which brings us to the most volatile reality of mental health nursing, honestly. The escalation cycle and the use of physical and chemical restraint.
Yes. The escalation cycle moves through distinct phases: calm, trigger, agitation, escalation, crisis, recovery, and post-crisis.
The professor's notes highlight a brilliant, totally counterintuitive exam question here. At which phase is verbal intervention least effective?
The answer is the crisis phase.
Why is that? I mean, shouldn't you try to talk them down during a crisis?
We'll understand why. We have to look at the neurobiology of crisis. When a client reaches this peak, their sympathetic nervous system has completely hijacked their brain. They are drowning in adrenaline and cortisol. Blood flow literally shifts away from the prefrontal cortex, which is the area responsible for logic, reasoning, and language processing.
Oh, wow.
And it funnels toward the primal brain structures, focused entirely on survival.
So their prefrontal cortex is basically offline, which means talking to them calmly, trying to reason with them, it's like trying to run software on a computer that's been unplugged.
It is entirely useless, and it can sometimes even aggravate the situation, as they may perceive your approach as a threat. During the crisis phase, verbal de-escalation is over.
So what do you do?
Safety measures become the absolute non-negotiable priority. This is when staff must execute trained physical interventions or seclusion to prevent immediate harm.
Conversely, interventions are most effective during the early triggering phase, right?
Yes, absolutely.
Like, if you notice a patient pacing right after a frustrating phone call, intervening then can stop the neurobiological cascade before the prefrontal cortex goes offline.
Exactly. And regarding restraints and seclusion, the golden rule of the NCLEX is that they are the absolute last resort. You must document that all less restrictive measures have failed.
Less restrictive meaning what?
Verbal de-escalation, offering oral PRN medications, decreasing sensory stimuli. Restraints are never used for staff convenience or punishment, and they must be removed the absolute second the patient is no longer a danger.
Right, so we've established how to communicate verbally, and we know the legal frameworks when physical safety is breached. But to actually treat these neurochemical imbalances and manage these crises, we have to rely on psychopharmacology.
This is a huge section of the exam.
The study guide emphasizes this heavily. Let's start with the king of mood stabilizers, which is lithium.
Lithium is fascinating because it isn't a complex synthesized molecule. It is literally a salt, a simple element.
Wait, really? Just a salt?
Just a salt. It alters sodium transport in nerve and muscle cells and influences the reuptake of neurotransmitters.
Yeah.
It is highly effective for bipolar disorder, but it has a notoriously narrow therapeutic index.
Meaning the margin of error between a dose that stabilizes your mood and a dose that destroys your nervous system is terrifyingly small.
Extremely small. For the exam, lock these numbers in your mind. The therapeutic range is 0.6 to 1.2 milliQL.
Okay, 0.6 to 1.2.
Anything greater than 1.5 is toxic.
And how does that toxicity actually present clinically? Because the study guide gives us the TICS acronym, TICS.
Right. TSI stands for tremors, and we are talking about severe coarse tremors, not just a slight shaking of the hands.
Severe tremors.
Then in coordination or ataxia, where the patient looks drunk and stumbles. C is for confusion, and S is for slurred speech.
So if you see a priority question with a bipolar patient presenting with slurred speech and a staggering gait, that is not an alcohol relapse. That is a life-threatening medical emergency. Now, here is where we get to the biological why behind the drug and diet interactions, which I find incredible. Ibuprofen, just a basic over-the-counter NSAI, can hurl a patient into lithium toxicity. How?
Yeah.
Why does that happen?
It comes down to renal physiology. Lithium is a salt, and it is excreted entirely by the kidneys.
Okay.
The kidneys have a really hard time distinguishing between sodium and lithium. NSAIDs like ibuprofen inhibit prostaglandins, which normally help keep the afferent arterioles in the kidneys dilated.
So blood flow changes.
Yes, when you take an NSAID, renal blood flow decreases.
Yeah.
The kidney panics, thinks the body's dehydrated, and starts fiercely reabsorbing salts to hold on to water.
Oh, I see where this is going.
Because it can't tell the difference, it reabsorbs massive amounts of lithium, trapping it in the blood and spiking toxicity.
It essentially clogs the filter.
Exactly.
But caffeine does the exact opposite. It lowers lithium levels.
Because caffeine is a mild diuretic. It increases renal clearance, forcing the kidneys to flush out water and salts, sweeping the lithium out with it, which can drop the patient's levels below the therapeutic 0.6 threshold, leading to a manic relapse.
So the physiological rule of thumb for you to remember for the exam is anything that causes dehydration, sweating, severe diarrhea, stomach flu, it concentrates the lithium in the blood and triggers toxicity.
Correct.
Let's move to antidepressants. We opened the show with the suicide paradox. Let's fully explain the biology behind it.
When a patient is in the depths of severe major depressive disorder, they exhibit anhedonia, which is the inability to feel pleasure. But crucially, they also suffer from profound avolition and anergy.
Which means
They have zero physical energy or drive. The psychomotor retardation is so severe they can barely get out of bed.
so they might actively want to die, but they physically cannot orchestrate a plan.
Exactly. Now, when we introduce an SSRI or another antidepressant, the neurochemistry begins to shift. However, the alleviation of symptoms is not synchronized.
What do you mean by not synchronized?
The physical energy and psychomotor drive return weeks before the cognitive despair and hopelessness lift.
Oh man, that is the terrifying window. For the first 2 to 3 weeks, they finally have the energy to act, but their brain is still telling them life is not worth living.
This is exactly why vigilant safety monitoring and suicide risk assessments are critical during the initiation of antidepressant therapy. The medication gives them the power to execute the plan the depression offered.
Another major pharmacological trap involves the older class of antidepressants, the MAOIs, monoamine oxidase inhibitors like phenelzine, trade name Nardil. The dietary restrictions here are literally life or death.
They are. To understand why, you must understand what monoamine oxidase actually does. It is an enzyme in your gut and your liver that breaks down certain amines, including a specific amino acid called tyramine.
Okay, tyramine.
Tyramine is naturally found in many aged or fermented foods, and it acts to release norepinephrine, which is a potent vasoconstrictor that raises blood pressure.
So usually your body breaks down tyramine from your food without a problem.
Right. But if a patient is taking an MAOI, that enzyme is blocked. The breakdown process is halted. If they eat foods high in tyramine, like aged cheeses, cured meats, salami, red wine, or pickled herring, the tyramine floods into their systemic circulation.
I picture it like a dam. The MAOI builds a massive dam in the river. If you throw a ton of tyramine into that river, the water level rises exponentially, the dam breaks, and you get a catastrophic flood.
And that flood manifests as a deadly hypertensive crisis. Blood pressure skyrockets to stroke-inducing levels, presenting with a severe explosive headache, palpitations, and stiff neck. Patients on MAOIs must strictly adhere to a low tyramine diet.
So no wine and cheese parties. Got it.
Definitely not.
Let's shift gears to a different chemical reality. Schizophrenia and the antipsychotics used to treat it. The exam will definitely ask you to differentiate typical versus atypical antipsychotics.
Let's look at the mechanisms. Typical or first-generation antipsychotics, like haloperidol, which is Haldol, and chlorpromazine, they work primarily by strongly blocking dopamine D2 receptors in the brain.
And what does that do?
They are highly effective at suppressing the positive symptoms of schizophrenia, so the hallucinations and delusions. However, they do absolutely nothing for the negative symptoms.
Okay.
And because they blockade dopamine so heavily, they carry a high risk of extrapyramidal side effects, which are severe movement disorders.
Whereas atypical or second-generation antipsychotics like risperidone, olanzapine, and quetiapine, they are more nuanced, right?
Yes. Atypicals block dopamine D2 receptors, but they also block serotonin 5-HT2A receptors.
And why is that important?
This dual action is crucial because it allows them to treat both the positive symptoms and the negative symptoms, like social withdrawal and flat affect.
Oh, that's a huge advantage.
It is. They generally have a lower risk of movement disorders, but they have a higher risk of metabolic syndrome, so weight gain, diabetes, and dyslipidemia.
But both classes carry the risk of a terrifying idiosyncratic complication, neuroleptic malignant syndrome, or NMS.
NMS is rare, but fatal if unrecognized. It is triggered by an acute, drastic reduction in dopamine activity.
What are the signs?
The classic triad of symptoms you must memorize: sudden high fever, altered mental status, and a profound lead pipe muscle rigidity.
Lead pipe rigidity.
Yes, the patient's limbs become completely stiff and unbendable.
Which sounds dangerously similar to serotonin syndrome, which is a condition caused by an overdose of serotonergic drugs, like mixing two antidepressants. How do we differentiate them on a multiple choice question?
They are easily confused because both feature fever, altered mental status, and muscle rigidity. But the biological mechanisms create distinct physical signs.
Okay, tell me.
Serotonin syndrome is an excitatory state. You will see hyperreflexia, meaning their reflexes are overactive and exaggerated, along with clonus, which are muscle spasms, tremors, and severe diarrhea.
Okay, so that's serotonin syndrome and NMS.
NMS, resulting from dopamine blockade, is characterized by that distinct, unyielding lead pipe rigidity and a lack of hyperreflexia.
That is a phenomenal distinction for the exam. While we are in the pharmacology section, let's rattle off the one-liner antidotes. If a patient overdoses on a benzodiazepine, an anti-anxiety med, what is the antidote?
Flumazenil. It acts as a competitive antagonist at the GABA receptor, reversing the sedative effect.
And if they overdose on an opioid, like heroin or fentanyl?
Naloxone, commonly known as Narcan, it forcefully kicks the opioid molecules off the mu receptors in the brain, instantly reversing respiratory depression.
Perfect. Now that we understand the chemical tools we're using, we really need to decipher the actual disorders we are treating. We mentioned schizophrenia briefly with antipsychotics, but we need to dive deep into the symptoms.
Schizophrenia is a complex syndrome characterized by a profound disruption in the architecture of thought, perception, and emotion. The exam requires you to categorize symptoms as positive or negative.
And to clarify, positive does not mean beneficial.
Right. It means something has been added to the patient's baseline reality. The brain is generating stimuli that do not exist.
Okay, like what?
This includes hallucinations, which are false sensory perceptions. They can be auditory, visual, olfactory, or tactile. It also includes delusions, which are false, fixed beliefs that cannot be corrected by logic or evidence.
Give me an example of a delusion.
For example, a delusion of reference where the patient believes the lyrics of a song on the radio are secret instructions meant only for them.
Wow. And within the category of hallucinations, there is one specific presentation that is the absolute highest priority for a nurse.
Surround hallucinations, yes.
Huh?
If a patient is exhibiting behavior suggesting they are hearing voices, you must assess the content of those voices.
To see what they're saying.
Exactly. Are the voices commanding the patient to harm themselves or harm someone else? A patient responding to a command hallucination to jump out a window is a paramount, immediate safety emergency.
Then we have the negative symptoms. This means normal human functions have been subtracted from their baseline.
Yes. The negative symptoms often start with the letter A. Avolition, which is a profound lack of drive or motivation, and hedonia, the inability to experience pleasure.
Right. Elogia, poverty of speech, where they might only respond with one-word answers.
And affective flattening, a blank, expressionless face.
So what is the clinical reality of interacting with these symptoms? I mean, if a patient is cowering in the corner, pointing at the wall and screaming that there are spiders crawling out of it, what do you say? You can't just say, no, there aren't.
No, you can't. You must navigate a delicate balance. The spiders are 100% real to their brain. Their visual cortex is firing. But as a nurse, you cannot validate a false reality.
So what's the technique?
You use a technique called presenting reality, or grounding. You acknowledge the emotional weight of their experience without confirming the hallucination. You say, I understand you are terrified, but I do not see any spiders on the wall. You are safe here in the hospital with me.
Validate the feeling, present the objective reality. That's great. Let's transition from psychiatric thought disorders to neurocognitive disorders. This brings us to the ultimate exam trap: delirium versus dementia. This study guide provides a whole chart for this because getting this wrong on the floor can literally kill a patient.
Let's frame it this way. Delirium is acute brain failure. Dementia is chronic brain decay.
Acute versus chronic.
Yes. Delirium is a medical emergency. It has a rapid, sudden onset over hours or days. The patient's level of consciousness will fluctuate wildly. They might be hyper-alert and combative in the morning and lethargic and unarousable by the afternoon.
And crucially, delirium is almost always caused by an underlying physiological issue.
Right. Precisely. It is a secondary symptom. In an elderly patient, a simple urinary tract infection can trigger massive systemic inflammation.
Really? A UTI?
Yes. Those cytokines cross the blood-brain barrier and hurl the patient into acute delirium. If you treat the UTI, the delirium clears and the patient returns to their baseline. It is reversible.
Dementia, specifically Alzheimer's disease, is the complete opposite in terms of timeline and pathophysiology.
Completely. Dementia has an insidious, agonizingly slow onset over months and years. It is driven by structural damage to the brain. The accumulation of amyloid plaques and tau protein tangles that slowly suffocate and destroy neurons.
That's a grim picture.
Think of it like rust and frayed wiring slowly consuming a house's electrical system.
And their level of consciousness.
Early in the disease, their level of consciousness is completely stable. They are awake, alert, and tracking, but their memory, particularly short-term memory, is deteriorating. And tragically, it is progressive and irreversible.
Which is why the pharmacological interventions don't cure it. The big three Alzheimer's meds are donepezil, which is Aricept, memantine, or Namenda, and galantamine or Rezidine. How do they work?
Donepezil and galantamine are cholinesterase inhibitors. In an Alzheimer's brain, acetylcholine, which is a vital neurotransmitter for memory, is depleted. These drugs block the enzyme that breaks down acetylcholine, keeping more of it available in the synapses.
Yeah.
It doesn't stop the rust from spreading, but it helps the remaining wires transmit signals a little longer, temporarily slowing cognitive decline.
Moving forward to stress, trauma, and anxiety disorders, we are shifting from how the brain processes reality to how it maladaptively processes fear and threat. What is the fundamental difference between acute stress disorder, ASD, and PTSD?
For exam purposes, the differentiator is strictly the timeline. When a person experiences a profound trauma, the amygdala, the brain's fear center, becomes hypersensitized.
Right.
The hippocampus, which usually timestamps memories so you know they happened in the past, fails to process the event correctly. This leads to the hallmark symptoms: hypervigilance, intense nightmares, and intrusive flashbacks where the brain feels it is experiencing the trauma right now.
So if a patient is exhibiting these symptoms 2 weeks after a car accident,
They are diagnosed with acute stress disorder. ASD covers the window from 3 days to 1 month post-trauma. Once those symptoms cross the 1-month mark, the diagnosis officially transitions to post-traumatic stress disorder.
let's talk about obsessive compulsive disorder, or OCD. This is often deeply misunderstood in popular culture as just, liking things tidy. The clinical reality is actually agonizing.
It is a debilitating neurological loop. You must clearly separate the obsession from the compulsion.
Break that down for me.
The obsession is a repetitive, intrusive, horrifying thought. A common one is, if I don't turn the doorknob perfectly, my family will die in a fire. This thought triggers a massive, unbearable alarm response in the amygdala.
And a compulsion is the behavioral response to that alarm.
Exactly. The compulsion is the ritualistic action, like touching the doorknob exactly 7 times, performed solely to temporarily neutralize the agonizing anxiety caused by the obsession.
Here's a question I hear a lot. If doing the ritual is the only thing that drops their anxiety, why don't we just let them do it? Aren't we torturing them by trying to stop it?
It is a compassionate question, but yielding to the compulsion reinforces the destructive neural pathway. The brain learns that the ritual is the only way to survive the anxiety.
Oh, I see. So it makes it worse in the long run.
Yes. However, your instinct about not causing suffering is vital for nursing interventions. You cannot abruptly stop a patient from performing a ritual.
What happens if you do?
If you physically block an OCD patient from the sink, their anxiety will escalate into a state of sheer unmitigated panic.
So what is the actual treatment strategy?
The gold standard is exposure and response prevention, or ERP. You collaborate with the patient, you purposefully expose them to the trigger, perhaps touching a slightly dirty surface, and you coach them through delaying the hand-washing compulsion.
That sounds intense.
It is.
Yeah.
You sit with them to the peak of the anxiety until their brain naturally realizes that the feared outcome isn't happening. Over time, you gradually decrease the time spent on rituals while building new neural pathways of tolerance.
It's basically controlled desensitization. Speaking of anxiety, we need to touch on the levels of generalized anxiety: mild, moderate, severe, and panic. The key identifier for panic level anxiety is a narrowed perceptual field.
During a panic attack, the sympathetic nervous system is firing so intensely that the patient's perceptual field shrinks to almost nothing. They literally cannot process their environment. They cannot hear your instructions. They may feel like they are having a heart attack or dying. The nursing priority is remaining with the patient, remaining calm, and using short, simple, direct statements.
Which brings us to our final major clinical section. When anxiety and trauma overwhelm a patient's coping mechanisms entirely, they often turn to self-destructive behaviors to regain control. We need to talk about substance use, eating disorders, and neurodevelopment. Let's start with alcohol use disorder.
As we discussed earlier with defense mechanisms, denial is the impenetrable fortress of addiction. A patient will fiercely rationalize their drinking. That's why the very first foundational step in any 12-step recovery program is breaking the denial and admitting powerlessness over the addiction.
But before we can get them to a meeting, we have to get them through medical detox. And alcohol withdrawal is one of the few withdrawals that will outright kill you. Why?
It's about the neurochemical seesaw of GABA and glutamate. GABA is the brain's primary inhibitory calming neurotransmitter. Glutamate is the primary excitatory neurotransmitter.
Okay, GABA calms, glutamate excites.
Right. Alcohol is a powerful central nervous system depressant. It acts like synthetic GABA. When a patient drinks heavily for years, the brain compensates by downregulating its own GABA receptors and upregulating glutamate to keep the body awake.
So their brain is essentially flooring the accelerator, which is the glutamate, just to counteract the massive brakes, the alcohol the patient is applying every day.
Exactly. Now, what happens when the patient suddenly stops drinking?
The brakes are gone.
Yes, the brakes are gone, but the accelerator is still pinned to the floor. The brain is flooded with unopposed glutamate excitotoxicity.
That sounds dangerous.
It is. Within hours, they experience tremors, sweating, and tachycardia. Around the 72-hour mark, they hit the deadliest phase. Delirium tremens, or DTs, characterized by severe hallucinations, profound confusion, and lethal seizures.
To monitor this, nurses use the CIWA scale.
The Clinical Institute Withdrawal Assessment for Alcohol. It quantifies the severity of symptoms like tremors, sweating, and nausea to determine the required medication dosage.
And the medication we use to prevent seizures and save their life.
Benzodiazepines like lorazepam or diazepam. Because benzodiazepines act on the GABA receptors, they effectively trick the brain into thinking it still has the calming effect of alcohol, smoothing out the transition and preventing the glutamate storm from causing seizures.
We also have to administer thiamine, which is vitamin B1.
Chronic alcoholism destroys the gut's ability to absorb thiamine. A severe thiamine deficiency causes lesions in the mammillary bodies of the brain, leading to Wernicke-Korsakoff syndrome.
What does that look like?
It's a devastating condition featuring ataxia, ocular motor dysfunction, and permanent, profound memory loss where the patient confabulates or makes up stories to fill in the gaps.
Wow. For patients who make it through detox and want a pharmacological deterrent to drinking, there is disulfiram, trade name Antabuse. It inhibits the enzyme that breaks down acetaldehyde.
Right.
If a patient on Antabuse consumes even a trace amount of alcohol, they will experience a violently ill, throbbing headache, severe nausea, and vomiting. Oh, and a quick factual recall for the California students. The legal driving limit is a blood alcohol content of 0.08.
Switching briefly to opioid withdrawal. Unlike alcohol, opioid withdrawal is rarely fatal on its own, but the suffering is immense.
Yeah.
The body, deprived of its synthetic endorphins, goes into overdrive. We assess this using the CIWS scale, the Clinical Opiate Withdrawal Scale. We look for symptoms like intense yawning, rhinorrhea, which is a runny nose, piloerection or goosebumps, and severe bone and muscle aches.
Let's transition to eating disorders. The two primary diagnoses are anorexia nervosa and bulimia nervosa. Answering questions on these requires recognizing the distinct physical findings resulting from the behavior.
Anorexia nervosa is characterized by an intense phobic fear of weight gain and a profound distortion of body image. The defining physical characteristic is starvation physiology.
Right.
They are significantly, dangerously underweight. You will see lanugo, which is fine, downy hair growing on the body to trap heat, amenorrhea, and severe bradycardia as the heart muscle waits away.
Bulimia nervosa, however, involves chaotic cycles of binge eating followed by compensatory purging, whether that is self-induced vomiting, laxative abuse, or punishing exercise. And the exam trap here is their weight.
Yes, patients with bulimia are frequently at a normal weight or even slightly overweight. Therefore, the nurse must assess for the secondary physical wreckage of the purging cycle.
Like what?
This includes severe dental enamel erosion from the gastric acid, parotid gland enlargement, giving the face a swollen appearance, and Russell's sign, which are calluses or scars on the knuckles from repeated friction against the teeth during self-induced vomiting.
And the most lethal complication of bulimia.
Severe hypokalemia. Critically low potassium levels caused by vomiting. Potassium dictates the resting membrane potential of the heart. Hypokalemia can trigger sudden, lethal cardiac arrhythmias.
Finally, we wrap up the clinical content with neurodevelopmental disorders. Let's look at autism and ADHD.
For autism spectrum disorder, the diagnostic criteria focus on two main areas: persistent deficits in social communication and interaction, such as poor eye contact and difficulty understanding nonverbal cues, and restricted, repetitive patterns of behavior, interests, or activities. This might present as self-soothing rocking, intense hyperfixation on a specific topic, or severe distress at small changes in routine.
And we must be unequivocally clear on this, as it is a mandated public health teaching point in the study guide. There is absolutely zero scientific or medical relationship between childhood vaccines and the development of autism.
It is a thoroughly debunked myth that has caused immense harm to public health. Moving to ADHD, attention deficit hyperactivity disorder. The core symptoms are inattention, hyperactivity, and impulsivity, often stemming from dopamine and norepinephrine deficits in the prefrontal cortex.
Which brings us to a fascinating pharmacological paradox. If a child is hyperactive, bouncing off the walls, why do we treat them with a central nervous system stimulant like methylphenidate, Ritalin, or amphetamine salts like Adderall?
It sounds counterintuitive.
That sounds like throwing gasoline on a fire.
It seems contradictory, but you have to look at where the stimulant is working. By increasing dopamine in the underactive prefrontal cortex, the stimulant actually wakes up the inhibitory executive control center of the brain.
Oh, wow.
Once the prefrontal cortex is stimulated and online, it can do its job, applying the brakes to the hyperactive impulses and allowing the child to focus.
But stimulants are still stimulants, which leads to the primary nursing consideration for administration.
They will cause insomnia. Therefore, the vital teaching point for parents is to administer the medication early in the morning to ensure the stimulant effect wears off before bedtime, preventing severe sleep disturbances.
Okay, take a deep breath. We have built the architecture. We've covered PEPLAW's interpersonal framework, the legal torts and involuntary holds, the dense pathophysiology of psychopharmacology, and the biological realities of psychotic, cognitive, and substance use disorders.
But having the knowledge is only the first step. The final test of your competence on the NCLEX is application. You will be faced with prioritization questions. You will be given a list of 4 deeply distressed patients and asked one agonizing question. Who do you see first?
Because in the real world, you can't see everyone at once. Triage is the ultimate test of clinical judgment. So, what is the framework?
You must adhere to a strict, emotionless hierarchy. Harm to self or others is always, unequivocally, the highest priority.
Okay, harm is number 1.
Yes. If violence or self-harm is imminent, that patient wins. If no one is actively trying to kill themselves or someone else, you move to physiological needs. Is an airway compromised? Are they in a lethal withdrawal state? And finally, you address psychosocial needs, anxiety, grief, delusions that are not commanding violence.
Let's run a simulation straight from the principles in the guide. You have a patient with Alzheimer's wandering the halls, a patient with OCD repeatedly washing their hands, an anxious patient pacing and crying, and a patient with schizophrenia who just told you a demon is ordering them to strangle their roommate.
The command hallucination dictating violence is an immediate, lethal threat to another human being. That patient is your absolute priority.
Okay, let's try a harder one. You have a patient grieving a divorce, a patient with generalized anxiety having a panic attack, and a patient with a known history of severe depression who suddenly appears incredibly cheerful and energized this morning.
That is our hope from the beginning of the deep dive. The suicide paradox.
Exactly.
The suddenly cheerful, depressed patient may have finalized the decision to end their life, bringing them a sense of peace, and they now have the energy to execute the plan. They're an immediate flight and mortality risk. They are the priority.
What about a patient pacing the day room with severe, moderate to high anxiety versus a patient taking lithium who's sitting quietly in a chair but slurring their words and stumbling when they try to stand?
The pacing patient is experiencing a psychosocial distress. The lithium patient is experiencing physiological collapse. Slurred speech and ataxia are the late-stage signs of severe neurotoxicity, which will rapidly lead to coma or death. The lithium patient wins.
Physiology always beats psychology when violence isn't a factor.
That prioritization framework will cut through the fog of the hardest questions on your final. But before we let you go to conquer those 78 questions, I want to leave you with one final thought, something pulled straight from the philosophy of your study guide. It states, "It is important for nurses to process their own attitudes, perceptions, and anxieties regarding patients."
It is perhaps the most profound concept we've discussed. We have spent an hour dissecting the patient's mind, their broken defense mechanisms, their chemical imbalances, their escalation cycles. But the patient is only half of the equation.
Right.
The nurse is the other half.
Think about it. If you are the primary medical instrument on a psychiatric unit, what happens when your own unexamined anxiety bleeds into a high-stakes crisis intervention?
It's a huge risk.
If you step into a room to de-escalate a paranoid schizophrenic patient and you are vibrating with unrecognized stress, anger, or fear, their hypervigilant brain will instantly pick up on your physiological state.
Your internal state literally becomes a clinical variable. The therapeutic relationship cannot function if the tool delivering the therapy is compromised.
Wow.
If you don't understand your own triggers, your own defense mechanisms, and your own biases, you cannot effectively heal someone else's. Recognizing and managing your internal landscape is just as vital to patient survival as memorizing lithium therapeutic levels or legal statutes.
It's all connected. At the beginning, we talked about how the diagnostic landscape of mental health is murky, that there are no clean x-rays to show you exactly where a patient's reality broke. But what you have now is the structural map of how to navigate that darkness.
You truly do.
You understand the profound biology of the medications, the rigid legal boundaries that protect human rights, the prioritization frameworks to save lives, and the understanding of your own human element in the process. You are ready. Best of luck on that final. You've got this.